Good afternoon, everyone. Let me briefly tell you about my PhD thesis, Novel Therapeutic Approaches in Sleep-Related Breathing Disorders. My name is Bardóczi. I'm a pulmonology resident in the Department of Pulmonology. And during my work, I meet many patients who are dealing with sleep-related breathing disorders. So I would like to improve on that to get a better quality life, and on my mission to find the best therapy to reduce the symptoms for them. As you can see, I'm working on 2 projects which address to this problem. My first project is investigating the effectiveness of GLP-1 analogs obstructive sleep apnea patient. It's a systematic review and a meta-analysis. Obstructive sleep apnea is a serious sleep disorder that involves collapse of the upper airwaves during sleep. 1 out of 4 people are affected, and it has several negative health effects, including the early death. Severity is measured by the apnea-hypopnea index by counting the numbers of apneas and hypopneas. In most severe cases, we usually treat it with the CPAP therapy. The major risk factor of obstructive sleep apnea is obesity. 58% of the cases are linked to excess weight. Therefore, weight loss is also recommended for this patient. Good news, we have some novel pharmacotherapy choices. I think most of you have already heard about the glucagon-like peptide-1 analog. These medications can regulate your appetite, can reduce adipose tissue while your muscles don't decreasing, and this diagram below shows how the drug effective in weight loss. But how they can work in obstructive sleep apnea. We know weight loss is recommended in obstructive sleep apnea patient, and we know the GLP-1 analog can help with weight loss, so this is one way. Furthermore, they can improve the airwave collapsibility and also has direct airwave action. And this study shows us how the drug can reduce the severity of the disease. But unfortunately, these medications haven't been implemented in the clinical practice yet, so our aim is to investigate that the GLP-1 analogs are effective treatment choices in obstructive sleep apnea. Our clinical question is, can GLP-1 analogs reduce the apnea-hypopnea index, thus leading to improvement in obstructive sleep apnea patient? Our patient population is obstructive sleep apnea. We want to compare the GLP-1 analogs with the standard of care. Our primary outcome is the apnea-hypopnea index by measuring the severity, and we have several secondary outcomes like body weight, body mass index, oxygen desaturation index, and minimum oxygen saturation. So our hypothesis is that the GLP-1 analogs reduce the apnea-hypopnea index. And our clinical implication is weight loss therapy with the GLP-1 analogs as a standard of care for patients with obstructive sleep apnea. Here you can see I did my systematic search in 3 different databases with the following search key, and after the flowchart of selection, we have 5 eligible full text. So now we can move on my results. In the first figure, you see the overall apnea-hypopnea changes among those who are receiving the GLP-1 analog. In this forest plot, you see 5 randomized control studies, which including over 300 patients, and the mean difference of the decreasing in apnea-hypopnea is over 7. And the coincidence interval of the mean difference falls within this range, as you see in the red box. That means our results are mathematically significant, but based on the table, you can see it's also clinically significant, important result. And now we can move on my second figure. It's a little bit similar. You see the change in apnea-hypopnea between those who are receiving the GLP-1 analog and the control group. In this forest plot, you see 4 randomized control studies, which including over almost 600 patients, with the mean difference of the decreasing in the apnea-hypopnea is over 4. And the coincidence interval of the mean differences falls within this range. And this means our results are also mathematically and clinically significant as well. So I want to show some secondary outcomes. In my third figure, you see the change in the BMI between those who are receiving the GLP-1 analog and the control group with the follow-up time. And in this forest plot, you see 3 randomized control studies, including over 500 patients. And the mean difference was the BMI decreasing is 1.7. And the coincidence interval of the mean difference falls within this range, as you see in the red box. So our results are mathematically and clinically significant as well. And the last figure I want to show you is the change in the body weight between those who are receiving the GLP-1 analogs and the control group. you see 3 randomized control study, including over 400 patients, and the mean difference of the body weight decreasing is over almost 5 kilograms. So the confidence intervals falls within this range. So our results all mathematically and significantly, mathematically and clinically significant. Our meta-analyses have some strengths because we only work with randomized control trial with a clinically important follow-up time, and they work with the same GLP-1 analog. That's great because we know what is the exact drug we can recommend for our patients, but we have some limitations. We work with a very small study numbers, but honestly it's a very novel field of research, and it's work with relatively small patient population. And also, my limitation is the same GLP-1 drug because we don't know how the other effects on obstructive sleep apnea. So our conclusion is GLP-1 analogs significantly improve apnea-hypopnea index in obstructive sleep apnea, so that means they can reduce the severity. So our implication for practice, use GLP-1 analog as a standard of care, and our implication for research, more comparative randomized trial would further to optimize the therapy and higher number of patients to reflect the real-life prevalence. My first project, I finished my manuscript, my article draft is ongoing, and our target journal is Sleep Medicine Reviews, which is a D1 journal. And now I can move on. My second project is comparing the effectiveness and safety of positive airway pressure therapies in Pickwickian syndrome. It's also a systematic review and a meta-analysis. But what is Pickwickian syndrome? Pickwickian syndrome was named after one of Charles Dickens' character, Mr. Pickwick, who has some typical features like obesity, sleepiness, snoring, and dropsy. And what it means clinically. The last few minutes I speak a lot about the obstructive sleep apnea, but here comes a new disease, the obesity-hypoventilation syndrome. These patients suffering from obesity, they have hypoventilating during sleeping, and because of that they have daytime hypercapnia and hypoxemia. When a patient has both, so the obesity-hypoventilation syndrome and an obstructive sleep apnea, we can call them Pickwickian syndrome patient. Without treatment, they get serious complications like high blood pressure, heart failure, pulmonary hypertension, and depression, and also fourfold increase the immortality risk, so we have to treat it. The most usual therapy we do is the positive airway pressure therapy, and our meta-analysis want to compare these two, the CPAP and the BPAP. But what's the difference between of them? The CPAP therapy stands for the continuous positive airway pressure therapy. They work with a single set pressure, blow constant pressure when you're breathing in and the same pressure when you're breathing out. But it's not as great for accommodating changes in breathing, but more affordable and simpler to use. What about the BPAP therapy? The BPAP therapy stands for the bilevel positive airway pressure therapy. They work with two distinct pressure settings, blow higher pressure when you're breathing in and lower pressure when you're breathing out, and often used to treat more complex sleep and breathing disorders, but it's less affordable and more complex to use. So our aim is to investigate that the CPAP devices are effective treatment choices in Pickwickian syndrome. So our clinical question is, can CPAP therapy be an effective treatment choice for Pickwickian syndrome? Our patient population are Pickwickian syndrome patients. We want to compare the CPAP machine with the BPAP machine, and our primary outcome is the arterial blood gas parameters, and our secondary outcomes, the mortality, the hospital research utilization, respiratory function, sleepiness, quality of life, and safety as well. Our hypothesis is that the CPAP treatment is an effective treatment choice in Pickwickian syndrome. And here you can see my clinical implication. So the CPAP treatment is an effective first-line treatment for patients with Pickwickian syndrome. I did some preliminary search with this search key in 3 different databases, and I found 3 high-quality randomized control studies. So my topic is feasible. I started the Prosper registration, but we didn't submit yet because we're waiting. I finished my first project. So I'm here, and I would say thank you for your attention with the words of famous physicist George Gamow. Science is not just about knowing things, it's about asking questions and pushing the boundaries of knowledge. Thank you for your attention. Bye.
Thank you very much, Anna. And I would like to ask you, do you have any data? Is there any difference between orally and subcutaneously administered anti-diabetic drugs effect, or you don't have any data about this? For your first project.
But that.
Is there any difference?
Can you the microphone?
Is there any difference between the effect of orally administered or subcutaneously administered drug?
Yes, we only, as I said before, we only, all the studies we have worked with one drug. This is liraglutide, which is only the subcutaneous form of the drug. I think, if I know well, only the, which is the drug name? I know the general name, the Ozempic and the Ribazuz, the semaglutide. So the semaglutide, which is can the orally intake one, but they don't investigate all the studies. Only they work with liraglutide, and I think it's because the liraglutide is go for the weight loss drug, and I think this is why they use it for this, because the other drugs are go for the type 2 diabetes treating. So.
Okay, thank you very much.
So thank you very much for a very nice presentation. And I'm just a dentist, and I'm curious that what is the standard treatment in your clinic regarding the sleep apnea?
For now, the sleep apnea, if somebody get diagnosed with the sleep apnea and it's a severe, we give them the CPAP machine. So,
okay, thank you very much.
Hi, congratulations. I have a question in relation to this previous question. So you said if there is a patient with a high apnea-hypopnea index, then you give CPAP to the patient, yeah?
Yes.
So is it obvious that we have to give these patients GLP-1 analog as well for every patient?
If the patient has is obese, we have to treat it because we get into the normal stage of the apnea-hypopnea index. But most cases, when you see not only the CPAP, we use the positional therapy, and we go send them to the ENT unit to see there is something in the mandibular and so on. So that's it. I think it's an obese patient. We have to try it.
Thank you very much.
Thank you for your presentation. I have a question about the GLP-1 therapy. So from which age could it be indicated? So from only in adulthood or for children as well?
If I know well, liraglutide can give over 12 years old, and the other drugs are a little bit different. I don't know honestly which, but the little one is 10 years old, and we can give these drugs to 70 years old till 75 years till. So,
okay, thank you.
Elderly patient as well.
So my question is a bit similar to Jean-Paul's question. So do you think there's a cause-effect relationship between the GLP-1 and the decrease of the AHI?
Yes, it's a very good question, because most of you, I think it's because of the weight loss. It's generating the decreasing of the apnea-hypopnea index, but not only this cause it, because the GLP-1 receptors are manifested in the lungs, and they have a direct effect on the lung and can improve the collapsibility of the airwaves, so can open the airwaves more or less longer if the weight loss don't go well, but they have improvement on the apnea-hypopnea index as well. So,
okay.
Yes.
Thanks.